Now, as we're going into the final phase, I I'm really excited to introduce um, Samantha Simmons, who will be sharing for a few minutes some important information. And next slide, please. We're all having such important discussions today, and I feel blessed all the time to be in the role that I'm in connecting with so many different stakeholders who I say to myself all the time, if they could only talk more together and connect more together, how much more we can advance all of the work that we have a shared interest in doing. And so I'd like to think about what's possible, what's tangible, because there's a lot of things that just aren't. And so one thing is there is strength in the growing numbers of decision makers who are really understanding the value of this comprehensive approach. I think sadly the pandemic has highlighted that for us even more. And I think this is a really important time for all of us to think collectively of what we can do, together. And one important initiative that is happening that is tangible and that any of you can certainly be engaged with is whole health in the states. And I will turn it over to Samantha Simmons to just tell you about that for just a few minutes, and then I'll come back and wrap things up. And don't go away because there's exciting things at the end as well. Samantha?
Right, thank you. Hello, everybody, and grateful to have a few minutes to chat with you today. I'm going to try to describe a program that I could take an hour to talk with you about in 3 or 4 minutes. So it's high level, but I'll provide some information at the end about how to participate. So I don't know if I can advance. Yep, okay. Are you doing the slides, Carolyn, or am I? Okay, I'll just say next. I think it's not working for me to do it. So high level, the Whole Health in the States initiative. You can hit next 3 times, please. It's based on existing successful state collaborative models. One of those is the Oregon Collaborative for Integrative Medicine, which I'm the president of and which is facilitating this work. And it brings together many different kinds of stakeholders within a state so that they can work together to remove barriers to whole person care and to optimize whole person care. It provides a foundation for these states to make their own collaborative that is sustainable over time and ultimately can partner on many other initiatives together and activities and other health conditions. So this inaugural project of ours with the Whole Health in the States initiative, the goals are to increase access to non-pharmacologic treatments for pain and to drive utilization of comprehensive pain care within a state. Next slide, please. This is a quick look at the pilot demonstration states that are participating. And I can't go into too much detail of why we chose these just in the interest of time, but I will highlight that we're grateful that we're going to have several different blueprints for how states can achieve this goal. It does look different in each state. It does look different geographically. There are a variety of things that make doing this state-based work really important and feasible way to address these barriers. So we're excited to ultimately have a different frameworks that people can use to achieve these goals in their state. Next slide, please. I'm not going to go into detail on what comprehensive pain care is because we've heard a lot about that all day in these excellent presentations. But I just want to take note, if you do next. One more time. The stuff on the right is covered. Next. The stuff on the left is not. Oops, a little far. That's okay. So largely the things on the right side of this model of comprehensive pain care are covered in Medicaid, and largely on the left they're not. So that's one barrier of access that we want to focus on. There are many barriers to access besides just insurance coverage, but that's one that we want to try to make these other services available to patients and remove that barrier. Next, please. Next, you can 2 more. There you go. So that's the goal of this work. There are several barriers to access. Insurance is one of them. And we've learned that it's not enough to just open the door. You also have to do a lot of things to drive utilization, or it can look like it doesn't work. We don't want to see that happen. So next. And go ahead and hit next probably like 4 times. Okay, perfect. So on the left, you see our strategies towards increasing coverage for uncovered evidence-based non-pharmacologic pain treatments within a state. We're in the thick of a multi-stakeholder, multi-sector 12-month consensus building process in these pilot regions. And stakeholders are broad. It's an exhaustive process, but it's really necessary to build that consensus within a state and co-create where the people with their boots on the ground and those leaders within the state to get to a tangible plan, a tangible proposal, and to work directly in partnership with the governors and with the state Medicaid agencies. Stakeholders include healthcare providers, pain patients, hospital systems and health clinics, the national VA, the state level VAs, academic health centers, health science teaching institutions and associations for other health professions, different advocacy groups and nonprofits who advocate for different pieces of people's access to health that don't just have to do with the healthcare system, and also looking to identify exemplary models of care. And on the right, you see our work towards driving utilization. It's not enough to just open the door. We have to do more to make a comprehensive pain care model work. And so a lot of where our experience lies in the types of organizations we work with, that we'll be focusing a lot on the provider education side and the policymaker education side. As you saw today in the presentations, that's a large barrier. And also developing tangible tools and resources that will help providers drive utilization, and partnering with other organizations who are picking up different pieces that we don't have experience or expertise in. Next, please. So go ahead and next couple more. One more. So the way to get involved, because this is such a high level overview, a pretty complicated and complex undertaking. If you are in one of the pilot states, please reach out to us at this email address. We are developing currently a really engaging web portal that people can, we'll build the infrastructure for this work. It will build some infrastructure for these state collaboratives, but it will also allow people from other states who want to participate and can start forming their collaboratives without kind of the exact same that work that we're supporting in the pilot states, but can get involved and explore how to become more involved as different funding resources are expanded. So we have a temporary landing page for this website. If you email us, we'll put you on a list to let you know when it's ready and invite you to become a member of that. And if you just have more interest in learning more details about this project, just set up a call with me. And if you have expertise to lend, we want to hear it. So that's just a super high level. And I hope you can at least get a picture of how it really does tie to a lot of the barriers we saw highlighted today, but also the opportunities and how we can maybe address those collectively within states. And next slide. This work is being funded by the David and Laurel Lovell Foundation. We appreciate their foresight in seeing how this work can help get us there. And I will pass it back to you, Amy.
Thank you, Samantha. That was wonderful. And so glad you were able to share that today and that we get to work together. It's all hands on deck. So for next steps, first, as we had intended at the beginning with our objectives, we hope that the presentations today have inspired some of you to take action in your own settings. And when you complete the short survey that we'll send out to you after this, and you'll find it on our website as well, let us know. That's one of the questions. We'd love to hear what you're going to do and if there's ways that we can be supportive of that work. Just to mention in terms of the partnerships that we have another symposium coming up this fall on November 10th about behavioral health in terms of comprehensive integrated pain management. And that is in partnership with the American Psychological Association. That's going to be another exciting symposium that includes payers, providers, and patients in a similar discussion around some of these issues. And we'll send more about that, but you can find that on our website too under Fall Symposium. And lastly, we are closing now, but we are going to play the 6-minute video for those of you who have a few minutes and want to watch this. Dr. Coley mentioned this video. It's fantastic. It's from his FQHC, and includes a patient there that has a wonderful story and talks about the work that they're doing at People's Community Clinic. So like to close with the video that we'll start for 6 minutes and thank all of you for your time and interest in this topic. And we look forward to seeing you at at more events in the future. All the best and thank you.
I'm Louis Appel, Chief Medical Officer for People's Community Clinic. At People's, we provide many services that are outside the scope of regularly funded healthcare. We've built programs and services that really speak to the needs that people have more holistically in their lives. That includes services like mental health, behavioral health services, nutrition and lactation services, health education, chronic disease services, medical legal services related to health harming legal needs. So we really try to look at the whole person and be able to be supportive of them in their lives in whatever way that they need.
My name is Fred Blackman. I'm a minister at New Life Austin, and I'm also on the board of directors here at People's Community Clinic. As a minister, I do several things, from teaching classes to visiting people in hospitals and nursing homes to, of course, preaching sermons. I became a patient at People's Community Clinic after a stay in St. David's Hospital. I was in the shower getting ready for work, and I felt a sharp pain in my back, and then my legs collapsed from underneath me. I was rushed to the hospital where they determined that I had a slip disc shoot out and hit my spinal cord. After about 5 surgeries and several other procedures, I was released. During that time, I lost my job and I lost my insurance. And the doctor who released me recommended that I come to People's Community Clinic for my follow-up.
When I first met Fred, he had just come out of the hospital. He had some severe back pain. He went in the hospital. 9 months later, he came out having to learn how to walk. He had to learn how to speak so his words weren't slurred. So he was depressed. He was unsure of which way to go.
When I arrived here, my life had basically been flipped upside down. I had always been strong. I was a runner. I was an athlete. And in an instant, all of that ended. And People's Community Clinic really, really helped get my life back on track.
For patients who have complex needs, I think we really take a team approach and an interdisciplinary approach. We have a whole array of wraparound services that we can provide and offer to patients depending on their specific needs.
The reason why I love People's Community Clinic is because we're an integrative clinic. And a lot of people may not understand what that means, but to me, what integrative health is putting patients at the center and looking at all the factors that influence their health. It's not just medication, it's not just injections or surgeries. If you look at what the evidence shows, first-line treatments now for complex chronic pain or for pain in general are things like acupuncture, behavioral health interventions, chiropractic and yoga. These things are actually now your first-line therapies. We're able to incorporate some of these in to actually create a program that can really benefit patients.
I don't think that a regular quote-unquote doctor's office would be prepared to meet the needs that I had. A regular doctor's office doesn't have a counseling department. There's just a doctor's office. And even now, working with the pain group, it's a group of people who have chronic pain, and we work together in this group with Dr. Sharad and other counselors, and we talk to one another, we encourage one another, we learn from one another. It's just an all-encompassing level of care that you can't receive anywhere else. Without People's Community Clinic, I don't think that I would be walking and talking and living life like I live life now.
There is an emerging evidence base that demonstrates that our health is made up of so much more than medical care. Texas has the highest number of uninsured people in the country. For many Texas adults, it's not enough just to have coverage, though. There's the whole other question of whether the insurance company will actually pay for the treatment that's been prescribed by the physician. In Fred's case, informal advocacy was actually enough because the insurance company was on notice that someone on the team knew how to operate within all of the systems. When we see people as whole people and treat all of their needs, then we enable them to go out and live their life at their greatest potential.
One of the privileges that I've had working at People's has been the diversity, the people that I've gotten to know that I normally wouldn't. And they deserve a place where they can go and feel safe and valued and cared for, and they deserve the exact same treatment that we all do.
Most of health really is not health care. So most of health and well-being is related to the other things that go on in one's life. So the social supports that one has, the context in terms of nutrition and where you're living and what kind of activities and social support you have. All of those things combine to be supportive of or take away from health. And a lot of that is things that happen not in the context of just a medical visit.
In my normal day-to-day work as a minister, I meet with a lot of people, and some of them, they need help that I can't provide. And when I can't provide that help, I say I know who can, and it's People's Community Clinic. Because of the care I've received at People's Community Clinic, I am better able to help others, whether it's through referrals to the clinic, by sharing my story, or just because I'm the better person that I am because People's Community Clinic has helped me. I am able to help others, and that really makes me happy.